the question and answer session there was a great segue into our surface decontamination discussion panel we have going on. There's clearly a lot of interest in this topic. We have four folks at the table today for this portion of the show. We've got John LaRochelle, Dr. Kelly Reynolds, who we've already introduced, Dr. Chuck Gerba, and Dr. Russ Olmsted. We'll start with Dr. Germ. I think that's really all I need to say. Dr. Chuck Gerba, well known in the industry. As before, we could say a million things about Dr. Gerba, but we probably don't have to. He's a professor of departments Environmental Science College over at the University of Arizona. He obtained his PhD in microbiology from the University of Miami, Florida. I hope you have family there and friends are out there okay.
Yeah. No, they washed ashore.
And he's a faculty member in the Department of Virology and Epidemiology at Baylor College of Medicine. He conducts research on the transmission of pathogens by water, food, and healthcare environments. He's been an author on more than 500 articles, including several books in environmental microbiology, and is a fellow of the American Academy of Microbiology and the American Association for the Advancement of Science.
Thanks a lot. I'm going to quickly introduce the topic here. Oh, those are all my conflicts of interest that I could remember. But what I want to talk about, nobody's used the term fomites yet, and that's the term we like to use, is really talking about inanimate objects involved in disease transmission as a classification. And just reiterate the importance of fomites in transmission. It's the process by which surfaces get contaminated, either by somebody touching a surface, sneezing on a surface, or you contaminate it with a cleaning tool. I shouldn't be overlooked, or the cleaning process in itself. And aerosol generation. Just washing your hands with a virus on it will contaminate the bathroom because the virus comes off your hands when the water hits it. So those are all kinds of routes by which fomites can be contaminated. And of course, the issue is when you touch that and you get it on yourself or self-inoculate yourself is what we've been involved in more. And eye frequency, hand frequency, and that serves as a reservoir too, which if you touch it again, you can take it off your nose, mouth, or eyes. I don't know if you know, the common cold is readily transmitted by rubbing it in your eye, for example. One of the things to look at in surface contamination is the nature of the surface. This looks at transfer of the MS2 bacteriophage, which we use as a virus for looking transfer because it's easy to work with. And what you learn here is there's a difference between relative humidity, the amount of viruses you're going to pick up off a surface or actually put down. Two is related to relative humidity, generally the 40 to 65% relative. You get a better transfer. That's what you see in most indoor environments, unless you're in Arizona. It was 13% last week. Okay, so there is a difference. Environment plays a role. And you look at this, you see the cleaner the easier it is to clean a surface, the easier it is to pick up a microorganism from that surface. Notice money is way down on the list. A good infection control method would be money wallpaper. Because even though you'll find a lot of organisms on money, it's very difficult to get them off. So one thing to always think about, I think in development of new ways of preventing disease transmission, is to look at surfaces that microorganisms can't come off of. You don't have to kill them if they don't come off and get them on your hands. So that's another thing to do it. One of the things I like to do is rethink life in the 21st century. Most of our time is spent indoors. Big difference from 100 years ago, and most of our time was spent outdoors. I've seen 70 to 80% of us work in an office or a building all day. We travel more than ever before, more than any generation in history. We spend less time cleaning in the home than the last generation, about 50% less than 50 years ago. We are less clean. I mean, laundry I like to use as an example because you're using cold water washes and mild detergents. Your grandmother would never wear your underwear because there's so many bacteria in it. It's really difficult to get a lot of bacteria, particularly thick like towels and that are very thick. So your laundry is far germier than the last generation, whether you realize it or not. And we spend more time in public places and bigger ones, bigger auditoriums, bigger cruise ships, bigger office buildings, more people in one location than ever before. So we're more mobile. We've learned a lot. Electronic devices can move microorganisms around fairly effectively because they're good carriers. Once you contaminate them, you can move them to another surface. So we share more common surfaces with more people than ever before in history. So you don't have to reach out very far to touch anyone anymore because you pretty much anybody that touched that doorknob, you're probably going to pick up what they had. Now, the effectiveness of cleaning and disinfectants depend on a number of important factors. I think human behavior enters into this too, and the amount of training you have in the objectives you're given on doing that too, and the target organisms. Not all disinfectants work equally against bacteria, viruses, molds, and other organisms out there. Type of disinfectants, wide range of different types of disinfectant with different activities, different needed concentrations, and anybody applying those has to be aware of that or trained in that aspect. Formulation of the disinfectant. Some formulations will not kill all germs and others will. Particularly quaternary ammonium compounds formulation plays a big role on its efficacy against different microorganisms, and that's why it's important to read the label. And bioburden, we heard about that. The amount of bioburden makes a difference. That's why cleaning surfaces is so important before disinfectant application. Method of application. We've and others have looked at, do you spray into your wipe? Do you wait 10 minutes? Do you use a cotton cloth? Do you use a microfiber cloth? How much demand is there in these products for the disinfectant itself and applicated? So it's much more of a complicated process than you might think. Dwell time varies a lot with disinfectants, from seconds to minutes to hours, actually, on some of them. So that plays a role, too. And the type of fomite. You have to worry about corrosive disinfectants, for example, cloth materials, soft surfaces, roughness. All fomites are not equal in what you're looking at. Ability of the organism to recover from a disinfectant. This hasn't been paid too much attention in this industry, but it's an issue in the drinking water and food industry. Like E. coli can undergo photoreactivation if you don't give it a strong enough dose, because it can repair itself. Adenovirus is a real big challenge with UV light in the water industry, because it's the most resistant UV light organism known, because it uses your host cells to repair its DNA damage. It's what I call a zombie virus. You kill it, but you get it in your stomach, it affects your cells, and your DNA repairs the damage that the UV light done. Multiplicity of reactivation, you haven't heard much about that here in the water industry. It's a worry, because real viruses will recomplement itself. In other words, you kill part of one virus's DNA or RNA, and another virus, you kill another part. And if both infect you at the same time, it reactivates the virus because it's got all the nucleic acid you can see. And this probably makes real virus one of the more chlorine-resistant organisms known, at least to the water industry. And it's not all about patients' rooms. We've been in this. I pretty much can find any kind of HAI bacteria by going to the cafeteria in a hospital. You can see all those people in their scrubs and their professional garb, and you can sample in these surfaces and see if we sampled 3 hospitals, just walked in there, and we found all of these on on the table surfaces, because people are going in there. And then the other thing is they don't use disinfectants like they do in the patient rooms. They use sponges. They don't soak them long enough. They only use quats sometimes. So I was quite amazed. So I don't think this should be overlooked. Another good area is break rooms are great areas. A recent study by Dr. Dauncey's group was great, where we put MS2 virus on the floor and found it detectable on all of these stations. So one of the things is, I think we have to pay more attention, the group should think about it, is low-touch surfaces. We're getting a strong feeling they're almost as important, if not as important, as high-touch areas, and I think it's an area that needs more investigation. Did the same thing in public restrooms and other areas that get contaminated. We have to really think about what goes in there, what's its probability to count, even if it's on the floor, if it's on the countertop. That doesn't mean it's immobile in that because of human behavior. I don't think we've documented human behavior as well. More goes on in the restroom than I thought I think is going on. But does hand washing spread microbes? What we did is we put viruses, MS2, on people's hand and said, just go wash your hand. The reason we got suspicious, we were finding all these bacteria, including HAI bacteria, on the faucets of no-touch faucets, yet there were bacteria on there. And we think it's coming when people put their hand on there, they can't control the water, ricochets the bacteria, ricochets it off, and then you put your soap on. And so basically you're in your contaminated behind the sink bowl, hand washing area. We were just amazed that just putting your hand under flowing water can make a difference. And it makes a difference whether it's automated or manual. You can control the flow rate, so you don't get that high whoosh on your hands. It's another illustration of how you can contaminate a surface by an event you didn't think might be involved in contamination of fomite. So a little more thinking. I also wanted to talk a little bit about the role of self-sanitizing surfaces. I think there's a role for those, and I'll talk about why in a minute. Like we've all heard about copper, silver, titanium oxide, silanated quartz. I think self-sanitizing surfaces add another barrier in infection control that we should probably pay more attention to and try to get a better idea of how effective they might be in the overall picture of hygiene and sanitation control. Issues involve how long are they effective, how fast do they have to act. We're used to looking at disinfectants from the standpoint of acting in seconds or minutes rather than hours. So is hours still good enough for self-sanitizing surface? Do you really need seconds or minutes? What's really the role of it? Those will have to really be done through modeling efforts, I think, to get a really picture and actually in placement in issues. But don't rule out a surface as a self-sanitized surface. It's slow in acting, because that may be all you need for a lot of environments in that. And I think that's one of the issues that has to be looked at. I will look forward to hard surfaces. I wanted to talk a little bit more about and the need for a multi-barrier approach. We've been talking about these hand hygiene and maybe surface hygiene and other aspects as individual entities, but they're all part of the infection control process. I just came from a drinking water meeting where and drinking water is probably the largest infection control operation in the world because it has to work all the time in making sure you're not exposed to pathogenic organisms. And the process there we were involved with was taking raw sewage and going to drinking water in a treatment plant. You're starting out with about 50 billion viruses per liter of raw sewage, and the guidance is get that down to none detectable in 100,000 liters by using a multi-barrier approach. The goal here in drinking water is so that we meet a standard of no more than a probability of no more than 1 in 10,000 infections per year. And I think that's what's lacking in this industry is a goal or an objective. How low do we think we can get this? We should be working towards probabilities of reducing it towards a goal. And the same thing with multi-barrier approach. What they do in drinking water, they give so many log credits for removal, like filtration, you get a 99% credit or 2 logs. Disinfection will give you up to 6 logs if you have a really good disinfection system. For flocculation, we'll give you 2 logs. And I think you have to start looking at the multi-barrier approach. How much credit do you want to give everything? How really good do you think you can get for hand washing? Should we give that a 1 log credit? How about disinfecting a room with bleach? Give that a 3 log credit? How about adding UV light to that? Give it a 4 log credit? I think what you need here is a multi-barrier additive approach where you're giving credit for every aspect of infection control. So much, what can you achieve with one object? What can you achieve with another? And in the drinking water industry, when they're going from raw sewage to drinking water, they have more than one disinfectant barrier they use, and they often use different disinfectants to hit different target organisms under different conditions. So what I kind of see here, where all of this should be going, is setting an objective, where you're going. The big thing with the drinking water industry I've noticed is they're regulated. They have to do this. There's no regulation that I see here. So it makes it kind of anonymous to me where you're going and where you're heading. And some aspect of this should move forward to what's the objective? What's the maximum tolerable number of infections, and how low can we even make that go? And I see that a big difference in the food and water industry is they have objectives they're moving towards for an infection control, and they set the number in the case of the food industry of tolerable number of infections. I think we need to assess the significance of low-touch areas in the spread of microorganisms. High-touch areas may just, organisms may not be as much concern as you think because they get diluted very rapidly. If a lot of people are touching them, you're rapidly bringing the numbers down to a level where it's a very low probability of infection, where if you do a high-touch area, there may be fewer touches, but you may be getting more organisms over time because you don't get that massive dilution effect with large numbers of hands touching a surface all the time. And I think we really need to develop models on human movement and behavior in healthcare environments, not just from a hand washing standpoint, but how people interact with their environment and how they need to move that. And non-patient areas need to be looked at very critically as reservoirs for a lot of microorganisms too. I think they've been overlooked, like nursing break rooms, cafeterias, whatnot. They don't get the attention for infection control as I think they probably should from what we're seeing. And we need to better ways of understanding. Dr. Reynolds and I have used the bacteriophages as models, and we've been quite amazed. Microorganisms move in ways we would not predict in indoor environments, and I think we need a lot more of that kind of work to get a better assessment of how microbes move. And we need more effective monitoring. I think in this industry, they do it in the water and food industry, and they have standards. You have to have no coliforms in drinking water. Irrigation water for food crops, no more than 126 E. coli. So they have objectives. You got to have an objective you can measure that is somehow related to either the efficacy of the treatment process or disinfection process, or the efficacy of the probability of somebody getting ill from that level of exposure. And that will give you some focus. What I see a lot in this industry, at least from surfaces, is a lack of focus, a lack of trying to measure something and achieve that measurable goal through a multi-barrier approach. And I think it's going to be difficult to make progress unless you start setting some objectives and some ability to measure these objectives in the future. Okay, done. You're going to get the next one.
Thank you very much, Dr. Gerba. Next up is Dr. Reynolds, who needs no introduction. Take it away.
I started my career in environmental microbiology in 1987. I was an undergraduate student, and I was washing dishes in Chuck Gerba's lab. So this is our 30-year anniversary of working together, and it has been quite an adventure. So I don't know if that ages me or you or both of us, but that's the story. So Chuck definitely touched on a lot of paradigm shifts, right? There were a lot of themes in his talk that are thinking in new ways about some of the problems we're trying to address. And in particular, I think what's really interesting is to think about how we deal with some of these issues, as he mentioned, in food and in water and in the regulatory environment around food and water. So EPA and FDA are using approaches in quantitative microbial risk assessment to set the goals that Chuck was talking about, and it's a little bit more of a difficult term in healthcare, but acceptable risk. But really what that means is how clean do we need to be, recognizing our environment will never be sterile, but how clean does it need to be to protect the patient, to reduce infection transmission to a level that is acceptable. So I think we need to sort of think about that. And one of the things I'm going to be talking about today is how QMRA, or quantitative microbial risk assessment, could help this industry do that. And it's used widely in food and water regulation. I have my disclosures listed there. I'm lucky enough that through the University of Arizona, there's a definitely supported initiative to develop research with industry. So a number of you in this room I have worked with, and I think it's a really good approach to make sure to bring those disciplines together with academia, industry, and government funding so that we can collectively approach research initiatives. So in talking about just a general overview of what I'm going to give you more examples of in a minute, we use a lot of microbial tracer studies, and it's being used a lot across our field in environmental microbiology. So as Chuck mentioned, to try and measure empirically in the environment, in the real world environment where people are following their typical behaviors and practices, how do microorganisms move? And we have been very surprised. We actually started a study recently, or over the last couple of years, we started it, but we had an opportunity to go into a newly built long-term care and skilled nursing facility. And when we were invited in, we were going to measure the microbiome of that environment and track how there might be changes in the microbiome that might be predictive of when an HAI organism might show up. So initially, we just got some baseline data. When the facility was being built, no one was in the facility yet. We got our baseline microbiome, the background plethora of microbes, if you will. And then we started noticing changes when the staff came in. So the procedure here was that there was going to be the management staff would come in, and then they would start hiring nurses, and there would be these mock trainings before patients would come in. And then they started trickling in patients. Only at first they had just 2 patients, and then 5, and then 10, and then we saw the first HAI. And all along this process, we were monitoring the microbiome. And we could see when new people came in, the biome shifted, not good or bad. It just shifts, it changes. And then we could definitely see when the patients came in, a different type of biome. And then we certainly saw markers of HAIs before we could detect them culturally. And so we're matching these samples together. So we're trying to develop new tools for monitoring and predicting when HAIs might occur and where they might be moving to. Now, because this was a skilled nursing facility and a long-term care facility, patients were highly mobile. So in these types of healthcare facilities, you don't necessarily have the luxury of isolating your patients that are positive with an HAI. They're moving to the dining room areas, they're moving to rehab facilities within the same environment, and there's lots of movement of microbes. So one of the places we first saw MRSA in our biome study was at the top of the wardrobe in one of the patient rooms, a dusty environment right underneath the air vent, certainly something we had to get a ladder to sample it. So nobody was touching that. So these low touch surfaces definitely are a part of the transmission cycle. So even if you're not touching it, when that air vent came on, and if these microbes were attached to the dust particles, there they go, they're dispersed into your environment. And so we need to think about other environments besides just the high touch environments. So I mentioned that we're using QMRA modeling approaches. Quantitative microbial risk assessment can help us develop those generalizable equations where you can put your own unique data in to then run through the mathematical algorithm to see what the outcome might be for your facility. And that's where we're trying to get more simulated scenarios that are site-specific, but with a standard template. And I'll show you some examples of that. Behavioral assessments are definitely an important thing for me. We want to know what people are doing during their practices and how their behaviors are driving exposure and how we characterize those exposure probabilities. And the last thing I'm going to give you an example of is discrete event modeling. We think that we can really start to develop models that can compare the relative importance of hand hygiene and surfaces. So we talk about hand hygiene as being that holy grail of what we need to achieve improved compliance on. But what I hear in the field is that, okay, I've cleaned my hands, but as soon as I touch anything, I'm recontaminated. So now what do I do? And so we know that an overall reduction of the bioburden in the environment has an impact on reducing HAIs and reducing the probability of risk. But we don't know much about the interrelationship or the cross-contamination potentials or where the most appropriate hand hygiene opportunities are. And they may be more than the 5 moments that have been currently described. So I'll go on through and show you some of our examples. This was the result of a skilled nursing facility. The diagram that you see, the small blue dots are where we put our microbial tracer, and then the red dots are where that tracer moved throughout just a few hours in the facility. So when we put our tracer on the team room, which is kind of the staff lounge, and then also at the nurses' station, we saw that it moved throughout the entire facility. Almost every patient room was impacted. Here we were specifically targeting soft surfaces, more difficult to clean. We think more difficult to transfer the organisms, but recent data is actually showing that it's not. When you sit on a couch, you get this plume of microorganisms released into the air, and Chuck's team has done a lot of research on that as well. And the other thing we were surprised at is that it's not just isolated to where the nurses are most prevalent, but we saw our tracer transferred to very remote areas of the facility, which is where we had independent living quarters. So completely different staff supposedly going into these environments, but obviously some central transfer sites in the facility where our tracer was moving. So these microbial tracer studies are very useful. I like them better than searching for ATP because, again, ATP doesn't always correlate with the microbes. And you have a viable culturable tracer that you're looking at, so it's susceptible to your disinfectants and it has similar survival in the environment as the pathogens we're looking for. Just some examples of our QMRA modeling paradigm. Essentially, we identify a hazard, and then we have standard estimates, if you will, that are published in the literature of dose response. If you're exposed to a certain dose, here's the response you can expect in terms of your illness outcomes, what % of the population will get sick if they're exposed at a certain dose. We have numbers for immunocompromised populations as well as healthy populations. And then a big component that is part of the QMRA paradigm is evaluating exposure. Now, exposure is where we have the greatest uncertainty in our models because we can't always predict what people are going to do and how patients are shedding and how many people are touching these environments, how many visitors are in the room. All of these can affect our predictions of what the exposure potentials are and the health outcomes are likely to be. But one of the things we do with our tracer studies are helping to inform our models. And so if we've contaminated a doorknob and you have some level of viruses that will die off just naturally by drying and over time on the doorknob, but let's say after die-off, about 50% will transfer to the hands of an individual touching that doorknob. And so maybe you end up with 100 viruses at that point, and then 10% will transfer to the site of infection, the orifice of the eyes, nose, or mouth. And then we can predict from that dose what the response is likely to be. So this is how we use QMRA to quantify these events that might be occurring in healthcare. And again, this is used a lot in water quality assessment and food safety. So this is, I think, my last slide, and just some examples of some studies where we've combined our tracer data with our QMRA modeling, and we've predicted in an intervention situation. QMRA is very useful for rapid assessment of interventions, but we can show, we did a study in a workplace where we seeded our tracer, and at baseline, the tracer moved to about 52% of the sites that we sampled in that building. After an intervention, which was a hand hygiene intervention, we reduced the spread of contamination down to about 17% of our sites being positive. And so those quantitative values translated to a reduction in risk of infection for respiratory and enteric pathogens by about 80%. And you can see some other, in the table to the right, some other environments that we've looked at, which include healthcare, offices, hotels, long-term care facilities, even households, and an EMS response, so first responders. You can see in some of these studies, and the highlighted in red, the outcomes that they've had. And so QMRA helped us evaluate this. The tracer studies helped us validate our models that they were working in their predictive factors. And you can see that the reduction in risk of illness is anywhere between 77 and 99%. Now that bottom column, or the bottom row, the EMS response, we had very low risk reduction, and that's because we had very low compliance with the intervention. So the QMRA models and the risk assessment can also help you evaluate the impact of compliance. And going back to, this was a EMS response team, going back to them and showing them what other studies have achieved and what their study achieved really was a message to them about the importance of compliance and how it translates to real risk. Oh, this is my last slide, I promise. So this is the discrete event modeling of environmental influences, and this is really new in its development, and it's really just kind of compartmentalizing some of the different variables we know that drive infection risk in healthcare. And the component I really want to point out is the hand washing opportunity. We're playing with our models right now to see if we can change. If you clean a surface one extra time a day, what's the impact? If you clean these 5 surfaces 3 times a day and everything else once every other day, do we have a different impact than the daily cleaning? So we're really trying to compartmentalize our processes and see what the impact is. And we can do this with hand washing opportunities as well. When is the right time to clean and when is the right time to wash hands, and how do these things marry with each other? So that's it. More to come. Thank you.
Thank you, Dr. Reynolds. Next is John LaRochelle, who is the technical leader for Sodexo's Global Environmental Infection Prevention and Cleaning Program. John has 30 years of environmental experience in environmental infection prevention, facilities management, and a variety of clinical settings. So you guys, it's the tribe of 30-year veterans up there today. That's exciting. John is responsible for over 600 healthcare locations within the U.S., within Sodexo, in 80 countries. So he has a wide breadth of experience and can really speak to surface disinfection. John?
Okay, thank you. And welcome, everyone. Appreciate your time and honored to be part of this group. Again, my name's John LaRochelle. I'm head of innovation for Sodexo's North American operations, but I also represent our global team on infection prevention in the environment. So focusing on innovations and best practices globally and really looking to how we can further our education and our knowledge about the environment. So the first slide I want to share with you is one that was first done by Dr. John Boyce and his team on before and after cleaning. And this is something we've replicated a couple times in different research and studies. So to the audience, what's your expectation of what should happen to the amount of organisms on a surface after cleaning? Yeah, we're supposed to reduce them. We're supposed to improve and reduce the risk of those organisms. But what we've found in the Boy study and what we've replicated many times is that we're making the problem worse. So fundamentally, we're not improving the process. So, we like to point at it's not one thing. This isn't a silver bullet. This isn't one thing. You have to look at the people, the process, and the technology that we're using in cleaning and disinfection end to end. It's not one person. It's not, one thing. It's a multitude of things. So we look at the housekeepers to start with. I've been with Sodexo for 30 years, but prior I was a housekeeper for probably 10 years. So I cleaned patient rooms, I cleaned ORs, and I will tell you without, it's the craziest thing. To try to clean 22 rooms a day in offices is almost a human impossibility. And that's the task that we put on these employees that are making $10 or $11 an hour. Try to remember the last time you made $10 or $11 an hour. So these housekeepers are forced to work 2 or 3 jobs just to put food on their tables. The processes are flawed. So there's a big difference between cleaning and disinfection. We have to first clean and remove the bio burden off that surface to allow that disinfectant to work. So the processes a lot of times are not followed. We also don't follow a consistent process. The cleaners are in a room once a day. And that's the only time that they're there. They clean that surface once a day. And from our friends at Diversity, they showed that the bed rail math shows the bed rails touched 250 times a day. We know that medical equipment is a no man's land of cleaning. Who cleans it? How do they clean it? What do they clean it with? So it's really, to comment and to reflect on our colleagues before me, is it's really an end-to-end process that everyone has to be involved and own it, not just the housekeeper. And the technology, lastly. The housekeepers today use technologies, I call them World War II technologies in a lot of cases. Try to find a technology that's 50 years old in that hospital, and you'll usually find it in the housekeeping department. Yet nursing and other clinical departments are using things such as single-use wipes, pre-saturated disinfectant wipes that give a higher success. Yet housekeeping, not so much. So it really is that people, process, and technology that we have to focus on. So we also know that, and this is a study that's been replicated a bunch of times, is that housekeepers only clean about 49% of the high-touch surfaces in a patient environment. This was a study done in 50 hospitals by Dr. Philip Carling. Dr. Atella replicated at UNC. Why is that? It's because housekeepers, and I can tell you personally from experience, they're visually cleaning. You need to be an Olympic athlete to try to clean 22 rooms a day. It's not physically possible. And by the way, you get 12 minutes to clean that entire room on a daily basis. And a discharge, maybe 30. So we have to look closely at how we're managing this and how we're focusing on it. So this is one of the key statistics to look at. We know pathogens are living a long time, and it was a fantastic presentation on biofilm, and that's something that we're really focusing on and trying to learn about. Dry biofilm is now understood to be one of the key challenges. Yet a lot of the processes that we're using, single cleaning and disinfection steps, chemicals such as bleach and other products, quats, that may not have effect on that organism or that group of organisms. We need to look at a multi-mode approach of cleaning, disinfecting, and what we believe is UV disinfection, those 3 steps to really eradicate and get to the common core of those organisms. Our disinfectants that we use today, quaternary ammoniums have been around forever, yet they don't meet regulatory guidelines, yet the majority of hospitals still use them. It requires a 10-minute contact time to meet regulatory EPA guidelines, yet we don't enforce it, and it's not achievable. The average surface will dry in 2 or 3 minutes. So what are we doing with the rest of it? So this is a major fail point of the disinfectants that we're using. There are more innovative and better technologies out there. This is from Dr. Boyce's team also, giving a lot of credit to Dr. Boyce here. But this is a study that was done looking at quaternary ammonium disinfectants in a phenomenon called quat binding. Quat binding is what we use to, make our, laundry detergent and our fabric softener work. But in the healthcare environment, when that housekeeper fills up that bucket of water, adds their cleaning cloths and mops to it, the quaternary ammonium parts per million will get sucked out of that disinfectant onto the cloths. In a lot of cases, this is kind of what you're getting at the end of the process. We also know that the disinfection equipment doesn't always mix it properly. So water pressure, temperature, the O-rings in our dispensing systems create failure points in disinfectants, along with quat binding, we're really relegated to no disinfectant at all in a lot of cases. This is from, Dr. Gerber and the team looking at the microbial contamination of cleaning cloths and mops. So the majority of cleaning cloths and mops are laundered in sometimes a household washer and dryer in the bowels and basements of a hospital or some faraway spot, and they don't successfully eliminate all those pathogens. This is an independent study that we replicated in a Boston hospital that showed a tremendous amount of organisms still left in those cloths. Because even in perfect laundering conditions, and most of the operations that we work in are not perfect. So there's single-use products that eliminate this risk and create a better success. Dr. Gerber talked about the contamination of floors. So Curtis Donski and his team looked at how pathogens travel from the floor to the touch surfaces and spread throughout the facility and rapidly. I'm amazed at the research that the Arizona team has done to really focus on how fast these pathogens travel. And the floors have been something that the housekeeping industry and the cleaning industry has been told, don't worry about it. It's not a challenge. It's not like the organisms are going to fly up from the floor, crawl up on the bed rails, and get on the patients. But the reality is that is exactly what's happening. And it's not staying in the patient room. It's absolutely moving around. So we have to focus on the entire environment, not just that room. When you put up that isolation sign, it's not a stop sign for these organisms to stop traveling. Hand hygiene. So one of the questions earlier today is we talked a lot about monitoring, but competency is something that is missing. I probably visited 200 hospitals in the last few years throughout the world, and I've found almost no place that has a competency-based training program for hand hygiene, and one consistently. Our idea sometimes of competency is giving people a PowerPoint questions to answer so they can check the box on their Joint Commission accreditation. But if you look at, and this is for healthcare workers, you look at the fail points for fingertips. How do you eat? How do you do treatment? It's with your fingertips. And your fingertips and the backs of your hands, your thumbs are dramatically missed. The people. So the housekeepers are the most passionate, loyal individuals that you'll have. But we're not giving them the proper tools, processes to be successful and enough credit. And to a point earlier, try to live on $11 an hour. It's just not possible. We have to examine this component if we're going to have true success in the environment. And lastly, all these things combined, this is the CDC study showing as the increase of bioburden increases on a surface, so does the likelihood of infection. What are we doing? All these things combined are contributing to that end result. So we have to change our paradigm and our thinking to really make a marked difference. Thank you for your time.
Thank you, John. Our final speaker in this panel is Dr. Russ Olmsted. He has 34 years of experience in the fields of infection prevention and control and healthcare epidemiology. He's the director of infection prevention and control for Trinity Health's Unified Clinical Organization here in Livonia, Michigan. Let me turn the page. This is a long list of accolades here, Russ. He's an associate editor for the American Journal of Infection Control and a member of the American Society of Heating, Refrigerating, and Air Conditioning Engineers, otherwise known as ASHRAE. He's been a member of CDC's Healthcare Infection Control Practices Advisory Committee from 2006 to 2010. His research interests include implementation science to prevent device-associated infection and the role of the environment of care as a reservoir for pathogens that cause healthcare-associated infections. Dr. Olmsted.
Very good. Thanks. Let me disclose that I don't have a doctorate, just a master's degree, but that seemed to be good on NPR a few years ago. So that's one thing I can point to. Also, hopefully we'll have time to ask Dr. Gerber and Dr. Reynolds how they feel about kitchen sponges. So that's for later on today. So designated here kind of give you the perspective certainly of the healthcare large integrated delivery network across the U.S. We have about 91 hospitals in about 22 states currently in the U.S. So a lot of landscape to cover. And as we've heard this morning, it's an extremely complex system for let alone one individual facility, but you start to multiply that by many facilities and lots of potential for challenges, I think, in preventing transmission of infection. A few disclosures on the Speakers Bureau for Ethicon Incorporated, and then also have done a lot of work with the Agency for Healthcare Research and Quality funded opportunities through the HRET, that's the Healthcare Research and Educational Trust, a division of AHA. So with that, I thought I'd start out. We've talked a lot about the kind of the interstate highways for microbial transmission. This at least offers a little bit of a model. It's a fairly small size font, but hopefully with the slides you'll be able to look at this a little bit more. But certainly on your left is the infected individual or the source of the microbes, many modes of transmission. Probably I think what we're realizing now in healthcare is there's likely multimodal transmission of pathogens from one place to the other. Certainly the classic focal points for infection prevention have been concerned about direct and indirect contact transmission. So that's been our name of the game, droplet. There's certainly some significant pathogens, I would say more community or population-based pathogens of concern. And then the classic airborne transmissible diseases like tuberculosis and measles certainly are moved through great distances through air. We'll learn a lot more about that tomorrow with our panel, so looking forward to that. Probably the one on the lower right there is what keeps me up at night mostly is Clostridium difficile. I kind of eat, sleep, and breathe that particular organism, as do my colleagues, because it certainly, I think, is the prototype pathogen for something that's got multimodal transmissibility, but also very high likelihood that it survives in the environment of the patient care environment and may, in fact, go to other areas throughout the healthcare facility. One important concept, however, is kind of my caution that I'll bring to the podium is don't always chase the microbe. So I can detect, and Dr. Gerber and Dr. Reynolds can do great recovery studies, probably find a pathogen just about anywhere, including this podium. Certainly on my hands, I'm carrying about 1,000 to 10,000 microbes of my own friendly flora. But we've got to have a combination of the agent, so the microbe that causes the infection, the host, that's you and I. What's our susceptibility to infection is going to differ greatly. So if I'm extremely immunocompromised, just received a progenitor stem cell transplant, I have a high risk for a variety of organisms. Probably many of those are environmental organisms that are in air and water. Much less so as I move out into a med-surg unit, even an intensive care unit. So, and then the environment certainly contributes to this risk. So we've got to kind of combine all three levels of this triangle before we see actual transmission of infection. The development of infection is going to depend on how we process that organism. So the mere exposure is not enough necessarily to cause actual healthcare-associated infection. Survival, we've seen some great data on this. Very nice review by Dr. Kramer and others, as well as updates on C. diff in particular by Dr. McFarland, and John Otter has done a great job. But clearly you can see C. diff guaranteed to almost have indefinite survival in the environment, probably at least a year. if not more. So it likes to hang around. Other pathogens of concern, certainly VRE, MRSA, are the types of pathogens we see that do cause healthcare-associated infections. Occasionally bloodborne viruses, although much more rare, except in dramatic situations, which include things like reusing sharp devices from one patient to the next. Obviously not good practice, but certainly we have seen those episodes. And then some unusual pathogens there. The other one that keeps me up a lot is norovirus. So that one can show up literally any area where you gather people together. So that's guaranteed to happen. Assisted living facilities, long-term care facilities, and acute care hospitals as well. But so this organism, it also brings cruise lines to a grinding halt. So if anybody on the ship has norovirus, it's an immediate evacuation. So abandon ship is, I think, what I'd recommend for that one. High frequency touch, we did talk about this. I still think we have good evidence about high frequency touch surfaces are really heavily contaminated or intermittently contaminated, probably on a more frequent basis. John is absolutely right. The floors are probably low on our list. That's primarily through advice from infection preventionists, because we don't feel floors are necessarily a major source of reservoir of pathogens. If you drop items on the floor, we want to assume those are contaminated. That's kind of the general principle. So think about what we do in the operative theater. We generally view the OR table as kind of that magical barrier where pathogens stop, but we face the patient forward, so we don't look at kind of what's on the floor necessarily as a significant reservoir. Doesn't mean that we can't have episodes of transmission from contaminated surfaces on floors, but most hospitals in the U.S. probably are using a neutral floor cleaner, because we've got generally patients and the public like a shiny floor, and it's very difficult to keep a shiny floor when you apply disinfectants day in, day out. Especially quaternary ammonium compounds are pretty tough on several of those flooring materials. So we do focus on these surfaces. There's some great work by Phil Carling and others looking at marking techniques for this, kind of a fluorescent marker to see how often people touch these surfaces and then how well we're cleaning those, and agree that it really is a team sport. We talked earlier about environmental services role. Quickly realized that all these devices potentially are also handled by direct care providers. So nurses, physicians, respiratory care, physical therapy, occupational therapy. There's a lot of equipment, kind of a mind-boggling array of devices that move from one patient room to the next. So I think that area is absolutely kind of the zone of inhibition right now. Nobody's really clear whose responsibility it is to clean those mechanical or patient care devices that probably are more the domain of those personnel that are actually using those devices for patient care. So mechanical ventilators, infusion pumps, kind of portable bladder ultrasound scanners, all those should be probably the domain of the personnel that are using those for direct patient care, making sure they're part of that disinfection team. So here's a clean room. How many think it's free of C. diff by chance? Yeah, not too many based on what we've been scared into today. So looks great. The surfaces look great. Everything's clean and ready for the patient room. This is probably more the reality. So we heard this morning about VRE. This is a pictograph of what a microbe, if we had microbial vision on. But this was a room ready for the next patient. It's been cleaned thoroughly by environmental services. The direct care team has cleaned all the patient care equipment, such as the infusion pumps and ventilator that you see here. The reality is, when this very nice work by Duckrow and others looked for contamination in these surfaces, and you can see about 10% were positive still for a multi-drug resistant organism like VRE. So clearly that room space is potentially a risk zone for the next patient who comes into this room. So is it safe? Are we free of C. diff? Probably not. Depends on who is in your room before you or who is your roommate and what they might be colonized or infected with. But a lot of evidence, you can see about 6 studies here, demonstrating that the room that you're admitted to places you at increased risk, not necessarily of infection, but acquisition of the organism that the prior occupant had. So, and that extends up to about 2 to 3 weeks before your admission. So my next advice, if you do need acute health care, call the infection preventionists and ask who was in which room and what did they have, and then look for a different room other than those chosen ones. So no, just being facetious. So, but I think clearly maybe the answer is curtains. The caption here is the patient in the next bed is highly infectious. Thank God for these curtains. So that may be one of our solutions to look at interrupting transmission. But the close, kind of the sense for infection preventionists, we look at space and time clustering. So how close are you to the source of the organism, and is there a cluster potentially within that patient care environment? So a couple of things to think about with that. Some new evidence that Dr. Larson and her colleagues was even more sobering to me recently, looking at not only is it who was in your room before you, did that person in the room before you get exposed to antibiotics? And there's definitely an increased risk if that prior occupant had anti-infective therapy, that your risk is higher for coming down with organisms like Clostridium difficile. So this one is expanding, I think, in scope quite a bit. And it's much more difficult to keep track of patients as they move through that. So just wanted to give you, now that we've scared you to death, how are we doing any better in healthcare? The answer is yes. We've had some significant improvements. Here's kind of the progress report based on CDC's National Healthcare Safety Data Network. The most recent report issued last year, about March. So for central line bloodstream infections, good improvement in prevention, about half of the infections that we would expect based on some national modeling data. CAUTIs, not so much, as you heard from Dr. Saint. We still have some challenges, I think, with device-associated infections, especially the urinary catheter. MRSA bacteremia, some improvements. Surgical site infections following abdominal hysterectomy and colon surgery, and then even C. diff, we've had some improvements on a nationwide scale. Here in Michigan, if you happen to book your room at one of our hospitals, hopefully you're not here for healthcare necessarily, but doing very well on prevention of CLABSI. A little bit of a challenge with CAUTI, so we're 15% higher in the state of Michigan compared to the U.S. MRSA bacteremia, about 3% left. Surgical site infections, depending on the site of infection, colon surgery a little bit higher, and then C. diff, pretty comparable to the national experience. So strategies for prevention, I think I'm using C. diff as kind of my prototype organism. Don't forget, I think it is really a team sport. We have to look holistically at this. So antibiotic stewardship absolutely is essential. Some new recent systematic reviews looking at the efficacy of antibiotic stewardship on multi-drug resistant organisms, including C. diff, demonstrate that has significant impact on lowering the frequency of those by upwards of almost 50%. So that's an important, essential piece that our clinicians can bring to the table, thinking about that use before we write that prescription. Appropriate testing, certainly very important in healthcare, especially around C. diff. We tend to either over-test patients, or we test patients who've got other reasons for their symptoms. So laxative use would be a good example. We don't always check on that before we order the test. We can end up with somebody who's merely colonized with C. diff, but not actively infected. Contact precautions, ongoing challenge for us, I think, in terms of getting folks to adhere to that. And then effective cleaning and disinfection, probably at the top of the list or very close to as important as hand hygiene. So environmental hygiene, absolutely essential, as we've talked about earlier. Some additional aspects of effective surface disinfection or decontamination, certainly properly cleaned environment, as we've talked about. Must clean that surface before. I agree totally with John. It's got to be cleaned before we can attempt to disinfect. All members of the team have a role, I think, in this. Some emerging technologies, including cloths in terms of design of those, process monitoring for thoroughness, and then no-touch disinfection is the kind of the hot thing on the market right now. Environmental services, really agree totally. It's got to be a valued, supported. They're essential members of the care team, making it safe for that patient. Some strategies that you'll be hearing more about, certainly ultraviolet germicidal radiation, vaporized hydrogen peroxide have been effective, and there's some efficacy evidence in the peer-reviewed literature that these help. Antimicrobial self-disinfecting surfaces, you can see those are listed there. Light-activated photosensitizers actually involves the painting materials that you put in the room can actually be triggered to elicit some antimicrobial activity by contact with sunlight. So there's some new technologies that are on the way. We talked a little bit about narrow spectrum ultraviolet, as well as kind of continual disinfection of surfaces. And with that, I think I introduced enough. Thank you very much for your time.
All right, we'll open this up for questions for about 10 minutes, and then we'll take a half-hour break.
Hi, this is for Chuck or Kelly. When you use the M2 bacteriophage, and you find it all over creation, or at least on the floor, do you test it at you test it for its presence, but do you test it for its viability? Is it still capable of infecting?
We're only testing for viability.
Oh, you do test for
Yeah,
viability.
it's only viability.
This question is for everybody in the panel. I just wanted to know if you had a chance to look at my presentation before you did yours, because everything that I was going to speak on, you've already covered. So thank you. A couple of things very, very interesting that you've brought up today on floors. I think floors needs to be a lot more attention needs to be paid to floors. You know, we talked about disinfecting floors, and that's one way, but that's only done once a day. What happens for the rest of the time when that floor is not been disinfected? And disclaimer, the next thing I'm going to say is my technology, so I'll talk about it. Floor coatings that has antimicrobial additive in it, that will continually work. Have you guys heard about that? Have you seen anything about that?
Not in floors, I don't think, in terms of antibacterial types of flooring. But one of the concerns with the floors, and I think the point has been made, we debate a lot about, okay, it's high touch, it's low touch, it's not that important. If something falls on the floor, it's taken out of service type of thing. But don't forget that dust just resuspends these organisms. You have your biofilms, your dry biofilms on dust particles, and these things can get resuspended into the environment. So I think every part of the environment is potentially a part of the contamination cycle to varying degrees, I would imagine. But you can't completely eliminate anything, and we really don't know what the frequency of disinfecting should be. That really hasn't been studied in a process or in a system, and I think that's part of what we're calling for in a change in textiles. And I think Russell mentioned that if you're using certain disinfectants on the floor, then you've completely stripped it of its coating. And so that's another factor. If we did have antimicrobial coatings on the floors, how long would they last? I think Chuck raised that question for other surfaces. So there's a lot of questions we still need to evaluate in terms of textiles.
And I would add one thing is that, we have to look at the entire environment. Your floors are your largest surface in your entire hospital, and they're very porous, and they have a lot of dust, so things do get airborne. And we have to shift towards disinfecting all surfaces, and we have to your point, look at technologies, whether it be copper, whether it be antimicrobial, and see what kind of effect and added benefit that can have towards that.
Yeah. So one of the things that we've done, just for information, is we've got a floor finish that has nano silver technology that's suspended throughout the finish. So as that finish wears, that technology, that nanotechnology is still there. We've just done some recent studies, and the results, like I said, I'm going to present that in the lightning round, but it's very promising.
Hi, I'm Brenda. I'm from Toledo. I apologize for being a Buckeye, being in Michigan. But I have a comment and a question. One is I understand the importance of having bedside caregivers incorporated into the disinfection process. I think where we're falling down is the training of those people. We expect that a nurse or respiratory therapist know how to clean a piece of equipment, but they don't. So I think that that's something for us just to be aware of. The second, I think we're getting kind of into a catch-22 with instructions for use and disinfection. We're being pushed to only follow instructions for use, but many manufacturers aren't testing all products. So then we have to bring in 10, 15 different products, and people don't know how to use them all. So at some point, as an industry, we have to come to a conclusion that we're using one disinfectant, two disinfectants at the most, so that the people that are using them know how to use them effectively. And I don't know if there's any kind of comment to that.
Yeah, I think this is Russ. Perfect point made, Brenda. I think we have one experience where one of our member hospitals, the imaging team was trying to disinfect a ultrasound device per manufacturer's directions, and ended up with, basically there were 3 different disinfectants compatible with different pieces of the entire ultrasound imaging. So, and the touch screen, which they use all the time during the patient exam, could not be disinfected. They said use a damp, clean cloth that's low corrosive activity on the screen. So what we're trying to do is open some discussions with manufacturers, realizing that medical device manufacturers have to answer to FDA requirements. So there's a FDA process, I think, that looks at cleaning disinfection as almost a 3-step process. That is extremely difficult for a busy clinician to do in that care environment. So I think I would probably propose that this kind of conference and also the collaborative or the consortium look at medical device manufacturers as well, because they're important players to bring. Many times we get instructions for use that specify exactly it's got to be Clorox brand dilute bleach wipe. Or the other one that I know and love, which I'm never going to use, is 2% glutaraldehyde for ultrasound surface probe disinfection. And these are the ones that are not the endocavitary, just the abdominal. But if you look at a lot of these IFUs, they have chemicals that I think are probably not safe for personnel to use, nor are they particularly effective. So I think there's a real opportunity for us in that regard.
Just seeing all this discussion in the patient room is, of course, very fascinating, but I didn't see any mention to other areas, say the operating room. Having spent a lot of time in operating rooms in those one-size-fits-none bunny suits, I can tell you that the anesthesia machine, is just filthy dirty every place I've ever been, right? It's supposed to be cleaned by the anesthesia techs, and if there's a C-arm there, that's supposed to be cleaned by the rad techs, and just looking at the way bacteria mobilize around the OR, I think would be an absolutely fascinating study, because if you talk to most people who talk about surgical site infections, they think, it seems like a lot of folks think it comes from the dog who licks your wound when you go home or something, right? But you talk to people who are there, and they tell you, God, stuff falls on the floor, we put bleach on the bed, and it gets cracks and stuff sits in there. Just seemed like that'd be an interesting study. Don't know if you had any thoughts on that or not.
Yeah, I mean, as a former cleaner in an OR, I can tell you that there is a big gap. There's so much equipment in those rooms, and it's really not designated. The cleaner is cleaning a lot of the high-touch surfaces, but is discouraged from hitting a lot of those high medical devices. And this is where we really need to look at what is the exact process, what is the exact products we're using, and what secondary levels, such as UV disinfection, can we employ to complement what the cleaners can't get. So it really is, we have to look at that. And again, like a lot of these questions during our breakout sessions this afternoon, this is something we want to keep living moving forward to figure out what our action items are as a group to move forward.
Yeah, would agree. I think that OR environment's probably one of the more challenging places. There are rapid turnover, a lot of people going through that environment. The one thing that I forgot to mention is, from the infection preventionist perspective, we spend a lot of time with our heads looking at microbes that we detect from patients. And when you look at the surgery population, we kind of look at a rank order of what is the usual suspects as we used. And in general, it's skin flora, the patient number one. Probably, I would say 40-60% of the time, that's the most concern. The technique and skill of the perioperative team and the surgeon, sterility of the surgical instruments, number two. And then third would be the environment. Certainly we recognize, but we put it kind of lower on that based on the outcome data that we collect. So we do look at what pathogens are recovered from patients with HAI, and that informs a piece of the puzzle. Likewise with catheters, it's for vascular access devices, predominantly skin flora. So it's probably that flora that either is on or in the patient, or that we move from our hands as we do care access to that patient. So that gives us some idea or intelligence about what are the modes of transmission, what are the likely pathogens. So that's an important perspective just to keep in place.
I'm a principal at a technology company that works with copper applications on high-touch surfaces. And a great panel discussion. Dr. Gerba, I appreciate the mention of low-touch surfaces. We don't hear enough of that. So, and it was mentioned again in more than one presentation. My question to you is, you mentioned common areas in terms of research. Is there, just to delve into that a little bit more, is it just less interesting? Is it there's lower concentration of bioburden? Is that part of the reason why we're not getting the right attention?
Well, I think it's an issue of you don't get the deep cleaning and disinfection in like a nurse's break room, or a break room in an office. It's quite interesting in the tracer studies that Dr. Reynolds did in offices. The first place it gets contaminated is a coffee break room. And so you get the viruses that we've seen spread among people who never meet each other. So I've always been really suspicious of break rooms as being centers, because you don't come in, you don't get the deep cleaning, you don't get the disinfection like they do in the patient's room or like an ICU unit. So I think that's an overlooked area, and it's a good place to trade germs.
And a quick question for Dr. Reynolds. Just curious, how's the uptake on the whole concept of the modeling of the transmission data? What's your success with getting this out there and adoption?
Yeah, so we've actually, in the last 2 years, made a concerted effort to try and go to the professional meetings and talk about these tools, and we've had some success in getting some funding from industry that is interested in helping us to promote these types of models. So we presented at APIC and AHE, had some really good response there. We published a few papers in the last year or two. And so I'm seeing some real momentum. Where we're really trying to get momentum is with NIH to fund these kinds of projects. So we are writing several R01s and R13 to try and get some of these projects funded, these project ideas. And the project directors seem very receptive of these new approaches. So we're trying to really drive these initiatives. But it really is a new paradigm. It's not new in general in microbial risk assessment, but it's new in this application in this industry. So I think it's going to take a little bit of work, and part of that work is being done here today with all of you. Thank you.
So I think a couple of you mentioned the importance of cleaning before disinfection. Could you comment a little bit about the use of EPA-registered products that are registered as a one-step cleaner disinfectant? In fact, do they do the job adequately?
Yeah, I guess I'll take that. The challenge is, if you look at the true guidelines for EPA guidelines for contact isolations, it says that the organic matter must be removed. And a lot of times that matter cannot be seen by the housekeeper. You can't leave it to the housekeeper's discretion when to clean it or not. So you really have to do that cleaning step first. Whether it be that one product, you have to still clean with that and then do the disinfection step after. So the one-step process is a fantasy. It doesn't exist. And it's, whether it's poor marketing or poor communication, it really shouldn't be done. You have to pre-clean first, especially in those contact isolation environments.
How often do you think that gets done?
How often does it get done currently? Very, very infrequently. The practice right now, and it's because, we're time constraint to our housekeepers, we're not giving them enough time to physically clean the room. We're pushing them through, so a lot of times they are actually doing the one-step process, and that's something we have to change and break that paradigm if we're really going to get to the biofilm and the treasure trove of the organisms.
Good afternoon. Thank you, panelists, for sharing your expertise. I found this session very productive. So just a really quick question, perhaps for Dr. Reynolds, but then for the other members on the panel, just to comment. Appreciating various host factors, what, in your opinion, is the ideal versus the acceptable? So let's just say, for sake of argument, ideal may be 6 log reduction, but what is acceptable for log reduction? And I would even take it one step further, acceptable log reduction for those adjunct technologies that Mr. Olmsted referred to.
Right. So that's a great question, and that's a question we've been investigating with our models is, again, how clean do you need to be? What's an acceptable log reduction? And there are some papers out there, one in particular, Ryan et al., out of Chuck Haas's group, another group that does microbial risk assessment modeling. They've looked at how clean a room has to be for reducing, say, MRSA concentrations to acceptable risk levels. And here's the thing that we run into that I think is a little misleading, is that when we go to look for these organisms in rooms, they're very difficult to find. And that's why we went to tracer studies, because we need a high enough load so we can show multiple log reductions of any interventions that we're showing. Because when I look for MRSA, I'll find 10% of the surfaces positive, but with 1 or 10. And so we know patients are shedding millions of these things, so I'm not sure why I can't find more when I look for them, honestly. But so if you look at the real values we see in the environment, then you would say, well, we only need a 1 log reduction if that's the concentration that's out there. And that's really what Ryan and his method looked at in saying, if you're addressing viruses, these have very low infectious doses compared to the bacteria. So for viruses, we need to achieve, I think he estimated a 3 to 4 log reduction. But for MRSA, he actually said, don't worry about it, because if you're getting the viruses, then you're going to reduce enough of the MRSA that it's in this acceptable risk range. Now, these are theories that are thrown out there, and so we need to, again, validate some of these assumptions with our models using tracer studies. I don't know that I would fully agree with that yet, but it's a starter for the conversation. And so we're really focusing more on how much log reduction do we need to have, how can we use these multivariate approaches and stack them on to achieve the acceptable, I won't say acceptable risk, I'll say acceptable reductions that we think we need to reduce the risk to a level where we can substantially reduce HAIs. So I don't know if that fully answers your question, but I'm aware of where we need to go with this, and people are asking those questions.
2 more quick questions from Jimmy and Andy, and then we'll break.
Panel, that was terrific discussion, really, really enjoyable. I was just thinking some of the work we've done and other people have done as well with peroxides and the catalase positive microorganisms, which are surviving those peroxide disinfection processes. Have you done any of that work yourselves or come across those issues?
Great question. No direct work that I'm aware of. The one closest we got was around non-tuberculous mycobacteria, which are notorious. And when you put those in a chamber inside a medical device, add a fan, it's a perfect, kind of the perfect storm, as we say. So it's kind of like Irma in the operating room, and probably the worst thing to combine. But that organism, we realize, almost impossible to disinfect without physically taking the device apart and scrubbing it. So the mechanical work on it, and then for those that are, notoriously resistant to peroxides, I think that's probably the best approach that I've seen. But that's I've not seen as much work on, kind of environmental surface disinfection around those that are more, catalase positive and resistant. So, good question.
With respect to cleaning, do any of you use forensic UV? In other words, look for blood and urine. We were getting complaints from our nursing staff. The bathrooms weren't being cleaned, so I slipped them a little UV flashlight and improved the cleaning a great deal in the bathrooms, especially in the ones where we have chemo being administered. So anybody have any comments on using UV to detect unclean surfaces in the operating room? We've used it and still do, but I'd like to hear if others have.
So we certainly use and promote using a fluorescent marker to determine if a housekeeper has actually wiped the surface. It's the best demonstrated process. Is ultimately the way that we want to look at it? No, because do we know that it was biologically effectively cleaned? But at least the marker program helps to teach the cleaner competency on at least wiping those high-touch surfaces. So the demonstration in the chart that I showed you where housekeepers were hitting 50% of the surfaces, it actually increased their compliance to wiping the surfaces by up to 90%. But I think the next generation is we have to get to a better determination of, is it biologically clean?
I'm not talking about staged analysis. I'm talking about a random checking in the operating rooms, for example, for cleanliness. Did they get all the spots off the floor? Did they get the bed clean? Did they get the walls? If you look at even in a cystis, where we've got cystic fibrosis, and you start looking at the walls versus the airborne spread, the walls are covered with stuff. So it's a tool that we've used, and I don't get any impression that people are using that tool in this setting. But I would advise trying that out, especially places you can make dark, like operating rooms and bathrooms, which could potentially be a source. You can detect that with the UV light.
Great point, but some will consider. Thank you.
Great.
We've used it in hotel rooms a lot. So yeah,
Don't bring it in a hotel room.
All right, thank you, everyone. We'll meet back here at 3. We have snacks over here on the table and coffee and water still, so see you in 20 minutes.